Anesthesia is one of the quiet technologies that made modern medicine possible. Without it, many procedures would be unbearable, unsafe, or technically impossible. The body is designed to react strongly to injury. Pain makes us pull away. Fear raises the heart rate. Muscles tense. A patient who feels every movement of a surgical instrument cannot simply decide to stay perfectly still. Anesthesia solves this by creating a controlled, temporary state in which pain, awareness, memory, movement, or sensation can be reduced or removed. It is not one simple condition. It is a medical toolset that lets clinicians protect the patient while giving surgeons the stillness and access they need. The most important word in anesthesia is controlled. People often describe it as being put to sleep, but that phrase is too simple. Sleep is a natural state that can usually be interrupted. Anesthesia is induced with drugs and adjusted for a specific purpose. Depending on the procedure, the goal may be pain relief, unconsciousness, muscle relaxation, memory loss, or a combination of all of them. These effects are separate. A person can be awake but numb. A person can be relaxed but not unconscious. A person can be unconscious but still need additional drugs to control pain or muscle movement. Anesthesia is more like balancing several dials than flipping one switch. Pain relief is called analgesia, and it is only one part of the picture. Analgesia means preventing or reducing pain signals so the brain does not experience a procedure as painful. But many operations require more than pain relief. Amnesia may be useful because the brain can otherwise form distressing memories of sounds, pressure, or medical activity. Paralysis or muscle relaxation may be needed when even small movements could interfere with delicate work. Unconsciousness may be necessary when a procedure is long, invasive, or too intense to tolerate while awake. The anesthetic plan depends on which of these effects are needed and how deeply they must be produced. General anesthesia is the type most people imagine first. It suppresses activity in the central nervous system enough to produce unconsciousness and a total lack of sensation. The drugs may be injected through inhaled as gases, or used together. During general anesthesia, the brain does not process awareness and pain in the usual way. But because the central nervous system also helps regulate breathing, reflexes, and circulation, general anesthesia requires close monitoring. The anesthesia team watches oxygen levels, breathing, heart rhythm, blood pressure, temperature, and depth of anesthesia. The goal is not simply to make the patient unconscious. The goal is to maintain a stable, reversible state until the procedure is finished. Sedation is different from general anesthesia because it suppresses the central nervous system to a lesser degree. It is often used to reduce anxiety, discomfort, and memory formation without fully removing consciousness. Sedation exists on a spectrum. With light sedation, a patient may be awake, calm, and able to answer questions. With deeper sedation, the patient may drift in and out and remember very little afterward. This is why someone can say a procedure felt like it took only seconds, even when it lasted much longer. Sedation can be extremely useful for procedures that are uncomfortable but do not require full unconsciousness. Still, it must be managed carefully because deeper sedation can affect breathing and protective reflexes. Local anesthesia works by targeting a specific area instead of changing the whole brain. A dentist numbing a tooth is the familiar example. The patient remains awake, but the nerves near the treatment area are prevented from carrying pain signals. Nerves communicate through electrical impulses, and local anesthetic drugs interfere with that signaling. If the message cannot travel from the tissue to the brain cannot interpret it as pain. This makes local anesthesia powerful for small procedures. It avoids the need for unconsciousness, usually wears off over time, and can allow a person to walk out shortly after treatment. The trade-off is that it only covers the region where the nerve signals are blocked. Regional anesthesia takes the same principle and applies it to a larger region of the body. Instead of numbing a small patch of tissue, clinicians can place anesthetic near nerves that serve an entire limb or body area. A peripheral nerve block can make an arm, leg, shoulder, or hand numb enough for surgery or strong pain relief. The patient may stay awake, receive sedation, or combine the block with general anesthesia. One advantage is that regional anesthesia can reduce the need for stronger whole-body drugs and may continue to relieve pain after the operation. But it requires precision. The drug has to reach the right nerve area while avoiding accidental injection into blood vessels or damage to nearby structures. Neuraxial anesthesia is a special form of regional anesthesia performed near the central nervous system. Spinal and epidural anesthesia are the best-known examples. These techniques interrupt incoming sensation from nerves supplying large areas, often the lower body. An epidural during childbirth is one common use. Spinal anesthesia can allow certain operations on the legs, hips, pelvis, or lower abdomen while the patient remains conscious. Because these methods act close to major nerve routes, they can be very effective with relatively focused drug delivery. But their location also makes technique important. Clinicians must consider sterility, dose, patient anatomy, blood pressure changes, and the exact level of numbness needed. Before any procedure, the clinician chooses drugs based on both the operation and the patient. The available drug categories include general anesthetics, local anesthetics, hypnotics, sedatives, dissociative drugs, pain medicines, neuromuscular blocking drugs, and other supporting medications. These are not interchangeable labels. Some drugs mainly reduce awareness. Some mainly treat pain. Some relax muscles. Some help prevent nausea or stabilize the body's responses. The plan may also change during the procedure. A short procedure may need only a brief effect. A long or complex operation may require changing drug levels over time. The anesthetic is tailored, not copied from a universal formula. The patient's health is one of the biggest factors in anesthesia risk. This matters because people often think the danger comes mostly from the anesthetic drug itself. In reality, the same anesthetic technique can carry very different risk depending on the person receiving it. A healthy patient undergoing a minor planned procedure is not in the same situation as an older patient with heart disease, lung disease, infection, or major trauma. The body must tolerate not only the drugs, but also the stress of the procedure, changes in blood pressure, possible blood loss, positioning, fasting, and recovery. That is why preoperative evaluation matters. It helps match the plan to the patient's real reserves. Anesthesia complications are often hard to separate from complications of the procedure itself. If a heart attack, blood clot, or severe breathing problem happens around the time of surgery, it may reflect the patient's underlying condition, the surgical stress, immobility, inflammation, or the anesthetic plan. Major perioperative risks can include death, heart attack, and pulmonary embolism, which is a dangerous clot traveling to the lungs. Minor problems are much more common, such as postoperative nausea, vomiting, grogginess, sore throat, or unexpected hospital readmission. The important point is context. Anesthesia is part of a larger medical event, and risk is shared between the patient, the procedure, and the technique. Some risks are more directly tied to anesthesia methods. Local anesthetic toxicity can occur if too much local anesthetic enters the bloodstream, affecting the nervous system or heart. Airway trauma can happen when breathing tubes or airway devices are needed, especially in difficult airways. Malignant hyperthermia is a rare but serious reaction to certain anesthetic drugs in susceptible people, causing a dangerous rise in body temperature and muscle activity. These examples show why anesthesia is treated as a specialty, not just a medication order. The drugs are powerful because they must temporarily override normal body functions. Safe use depends on knowledge, preparation, monitoring, and fast response if something changes. The achievement of anesthesia is that it lets medicine cross a boundary that the body normally protects fiercely. Pain and awareness are survival systems. They warn us, force us to react, and prevent injury from being ignored. Surgery sometimes requires temporarily quieting those systems so damage can be repaired, disease can be treated, or diagnosis can be performed. Anesthesia can block a single tooth, numb an entire limb, calm a frightened patient, erase memory, relax muscles, or create full unconsciousness. The best anesthetic is not the strongest one. It is the one that provides exactly the right conditions for the procedure while allowing the patient to return safely to normal sensation and awareness afterward. If you found this helpful, please like this video and subscribe for more explainers.